I would request our chairpersons to call our speaker for this session, Dr. Alok Nath, sir. Pen drive.
Hello. I welcome Dr. Alok Nath, who is a professor and head pulmonology, SGPGI Lucknow, and he is going to deliberate on a very important topic, asthma in pregnancy, during pregnancy. So this combination is very important, and largely it is missed, undertreated, and an important comorbidity during the pregnancy time. So we are going to be
asthma in pregnancy.
enriched with the knowledge of this deliberation. Thank you, and I welcome again Dr. Alok Nath.
Thank you, chairpersons, and very good evening to all of you. A very good evening to all the esteemed pulmonologists and experts amongst the audience. Today, I'll be deliberating on a topic which is of a common management interest for all the pulmonologists, that is management of bronchial asthma in pregnancy. It is commonly under-recognized, as sir already pointed out, that it is not very much recognized during pregnancy, and a lot of patients with asthma do not understand the importance of its management in proper fashion. So the burden of maternal asthma is around 4 to 12%, which is the global prevalence of this condition. However, it is very important to understand that asthma is most common chronic condition which a pregnant patient suffers from, which is seen by the practicing obstetricians and gynecologists all over the world. And because of the physiological adaptation during gestation, which complicates the respiratory function during pregnancy, it is very important to understand the global epidemiology of maternal asthma, which varies too much from region to region, and there is a lot of variation which is reported in the prevalence of maternal asthma. Maternal asthma prevalence ranges from 0.3% to 17% from population to population and from area to area. And this regional disparity gap estimates the major importance between the high income versus the developing country. And the lowest level is documented from Indonesia, that is around 0.3%, and the highest is seen from the developed nations like Australia, which tops at around 17%. The subcohort analysis also indicates that there are clear epidemiological clusters also. From the data from the US shows that there is substantially higher rate found in the black women and lower income quartiles. And temporal trends also show that US and China, the overall maternal asthma burden is steadily rising because the obvious reasons of air pollution, ambient air pollution, outdoor air pollution, and the lifestyle changes and lifestyle habits. From India, the estimated prevalence of gestational asthma ranges from 1 to 4%. And the National Family Health Survey reports that the self-disclosed bronchial asthma rates to 15.4 per thousand population amongst the reproductive age grade. So this is an extrapolation of the National Family Health Survey, but it is grossly fraught with underreporting because of various stigmas attached with the respiratory conditions, and a lot of pregnant patients, because of the overall socioeconomic status or the social stigmas attached to the condition, lot of patients suffering from bronchial asthma in the maternal age or among the females do not report the symptoms. Longitudinal trends demonstrate a sharp age gap gradient also. That is, the lowest prevalence is observed from the 15 to 24 age group, and which climbs up, and highest is seen in the 35 plus age group. There is substantial variation exists across the regions also in India, in which the Kerala, Rajasthan, and distinctly northeastern region consistently exhibit a higher respiratory disease burden, especially bronchial asthma, and social disparities also affect the global and the Indian epidemiologic pattern. The biomass and household smoke, rapid urbanization and seasonal exacerbation profiles are also very much important in the Indian context, because of which the asthma prevalence, and more importantly, which I am talking about especially, is the the national maternal asthma burden is also increasing because of these important factors. What happens to a patient with asthma during pregnancy is now important to understand. It classically follows the rule of third. That is, around 1/3 of patients of bronchial asthma remain stable during the course of their pregnancy. 1/3 will improve during the course of pregnancy, and 1/3 will worsen. It is important to note, or it is very interesting to note, that around 50% of it, or I must say it is very unfortunate to see that around 15% of pregnant women reduce or discontinue their asthma medications early in pregnancy because of fear of the input from various non-verified sources that it might harm the fetus or it harm the outcome of the pregnancy, which is absolutely incorrect. And asthma, at the background of its epidemiological prevalence of around 4 to 12%, this discontinuation compromises the course and directly increases the risk of severe maternal and fetal outcomes. Why all this happens, that 1/3 remains stable, 1/3 will worsen, and 1/3 will improve, is all because of various physiological and adaptation which happen during the pregnancy, which are mainly driven by the hormonal imbalances seen during pregnancy. There is increased estrogen and progesterone levels, which increase the chemoreceptor sensitivity at the medulla oblongata, and it directly stimulates the hypothalamic and medullary respiratory centers, which increases the minute ventilation by increasing the respiratory drive and increasing the tidal volume. But it is interesting to note that despite tidal volume being increased, the respiratory rate remains stable. So whenever you see a patient who has bronchial asthma, is complaining of dyspnea, or is pregnant and complaining of dyspnea, and says that she has awareness of dyspnea, but the respiratory rate is normal, it may be dyspnea of pregnancy, which I'll be talking about later. Minute ventilation increases, boosting the PaO2 and slightly decreasing the PaCO2, and which results in mild compensated respiratory alkalosis, which is physiological and which is important for better oxygen transport across the placental barrier. This diagram shows the same thing which I was just explaining. Another thing which is important to understand is the change in the spirometric variables. We can see that there is increase in the inspiratory reserve volume, increase in the tidal volume, and increase in the total increase in the vital capacity. But interestingly, the total lung capacity remains stable. And you do not see any obstructive or restrictive spirometric pattern despite these changes, which are seen due to mechanical and physiological adjustments. So any abnormal spirometric variable is abnormal in pregnancy. Do not take it as it is because of physiological adaptations during pregnancy or during gestation. So further, elaborating upon that anatomical and mechanical lung volumetric changes are there because of diaphragmatic displacement, because of rib cage remodeling, but the spirometric integrity remains the same. That is, crucially, FEV1, FVC, and FEV1 ratio do not change at all. Now there are changes at cellular level also. A delicate hormonally guided immunomodulatory balance is required for better outcome or acceptance of a semi-allogenic kind of a foreign material in a pregnant woman's body. So for the acceptance of fetus, there is Th1 suppression, there is Th2 polarization, and this has a direct impact because asthma is a Th2 driven condition, and if the Th2 inflammation increases, you can understand that the control of asthma can also get worsened during the course of pregnancy. Furthermore, there is decrease in cell-mediated immunity, and which predisposes the asthmatic patients to various viral infections, especially influenza, common cold viruses, and nowadays especially COVID-19 also, which can predispose the patient to a cascade of exacerbation, leading to worsening of asthma control and leading to exacerbations. And these exacerbations are an important trigger of development of preeclampsia, IUGR, and other complications related to pregnancies. So there is a bidirectional relationship between pregnancy and asthma. Pregnancy has effect which leads to poor control of asthma during pregnancy, and a poor control of bronchial asthma has an adverse effect on maternal and fetal outcomes. So it's a kind of a bidirectional relationship with a vicious cycle which has interdependence on each other. So as I told earlier, that it is very important to differentiate dyspnea from pregnancy of dyspnea of asthma from dyspnea of pregnancy. The physiological dyspnea, which occurs in around 70% of pregnant patients, is because of various mechanisms which we have just seen in the previous slides. But whenever you come across a patient who has complaints of dyspnea, but there is tachypnea, is abnormal. That condition has to be seen with caution. Again, if you find a patient with asthma and the spirometry is not normal, you should investigate for the reason for development of that spirometric abnormality, and any obstructive defect should be taken as an indicator towards bronchial asthma unless otherwise proved. Now the probability of exacerbation also increases during pregnancy, and the risk of developing a severe asthma exacerbation or asthma exacerbation is directly correlated to the pre-gestational asthma control. As you can see that in patients with severe or moderate asthma, the exacerbation rates during pregnancy are up to the tune of 50% to 65% during the course of pregnancy. And the primary predictor of these impending exacerbations is history of prior exacerbation, prior inhaled corticosteroids burden during the pregnancy. There is a lot of noise from background. Can you please... Can someone ask them to keep quiet, please? Yes. So, and there is abrupt ICS reduction and cessation, and also obesity and gestational weight gain has got also a poor or adverse outcome on maternal and fetal health.
So I would request everyone at the back, please do not make a noise. There's a disturbance during the lectures.
Hypoxemia, maternal control of asthma all can lead to various complications like preeclampsia, congenital malformations, low birth weight, small for gestational age, placental abruption, and neonatal hospitalization. There is high quality to reasonably high quality evidence to support that poor asthma control is directly related to all these complications during or after pregnancy. And also there is the common question which everybody asks, that if the mother has asthma, is there a chance that the progeny or the further, the children will also have asthma? The answer is yes. There is threefold increase of developing asthma in children who in pregnancies where mother has got bronchial asthma. And it directly correlates with childhood wheeze, allergic rhinitis, and development of food allergies also. So now coming on to the evidence-based gestational pharmacotherapy. Before starting pharmacotherapy, we must be sure and we should confirm the diagnosis of asthma as far as possible and make all the efforts to confirm the diagnosis, for which spirometry and peak expiratory flow rate are gold standard. I think everybody will come across a pregnant patient who has symptoms suggestive of asthma, and globally and in India also around 40% of clinicians, physicians and chest physicians, they have hesitation in performing spirometry during pregnancy. I think all my seniors and my colleagues will agree to it that lot of patients as well as chest physicians and general physicians, they have hesitation in performing spirometry. But let me tell you, it is beyond doubt, and there is extensive body of research which says that spirometry is absolutely safe investigation during pregnancy. So it can be performed. The criteria for documenting obstruction remains the same as in general population, and also the criteria for reversibility also remains the same. Now, in absence of a spirometry, when the patient is unable to perform or you do not have availability of that particular test, nowadays fractional exhalation of nitric oxide is a very important non-invasive marker for airway eosinophilia, and British Thoracic Society, International Society for Obstetrics and Gynecology, the NICE Guidelines UK, as well as American College of Chest Physicians, all have recommended that FeNO combined with compatible clinical features and eosinophilia are enough to make diagnosis of bronchial asthma in absence of spirometry. And now the new kid in the block is impulse oscillometry, in which you do not have to do a forced expiratory maneuver, because of which lot of females who are pregnant and the caregivers or the chest physicians are hesitant to perform the procedure. IOS can give you a good indication of presence of airway obstruction in absence of standard spirometry. Bronchial provocation test and skin patch testing is absolutely contraindicated during pregnancy and should never be performed. Biomarker stratification using FeNO is important, that levels more than 50 parts per billion are very much suggestive of airway inflammation, which is eosinophilic in nature, and levels less than 25 should stimulate you to search alternative causes of breathlessness rather than incriminating bronchial asthma in your diagnosis. So during pregnancy, you should make all efforts to make the diagnosis of bronchial asthma, and cough and dyspnea are a common complaint during pregnancy, so they should be differentiated between whether it is due to asthma or it is due to common other conditions like esophageal reflux disease, pregnancy rhinitis, which is because of congestion of nasal airways and air passages because of the effect of estrogen and progesterone, or it is post-viral cough by the typical features which are listed in this table, and one should try to differentiate the bronchial asthma with all these conditions. Now, during pregnancy, the treatment should start with the assessment of comorbidities, because various treatment or treatable traits are identified during pregnancy, amongst which the most important is synergistic comorbidity risk in form of obesity, which is seen in around 30 to 60% of patients with pregnancy. There is gestational weight gain, which is more than physiological, which has got an impact which is adverse in patients who are pregnant. There is elevated odds of development of GDM, that is gestational diabetes mellitus, and it is associated with 36% increase in maternal asthma exacerbations. There is glucose-driven exacerbation risk also, that is doubling of serum glucose levels, which is from the pre-gestational values, directly doubles the risk of exacerbations. Polycystic ovarian syndrome has got a bidirectional relationship, which is showing a 75% increased odds of baseline asthma as compared to patients who do not have PCOS. So it is clinically imperative to see and identify these metabolic treatable traits before or during the course of evaluation, so that you can identify the correct, identify these traits, treat them adequately for a better outcome. One of the most important and most overlooked things during pregnancy is the maternal anxiety and depression burden, which around 50% pregnant patients suffer from depression, and 50% suffer from anxiety, and around 40% patients suffer from depression, which should be adequately addressed because psychosocial issues or psychosomatic issues have got a direct impact on asthma control, and they should be addressed very carefully during management of asthma. OSA, gastroesophageal reflux, is a common accompaniment in patients with pregnancy because of mechanical reasons. GERD is highly seen, and because of gestational weight gain and obesity, OSA is seen or confronts around 4 to 27% of pregnancies. They should be clinically evaluated and adequately managed. So a high-risk trajectory should be identified in form of history of any maternal smoking, social deprivation, poor medication reference, presence of nasal polyposis, diagnosis of severe asthma requiring hospitalization, or history of any previous exacerbations previous to attainment of gestation. Presence of obesity, diabetes, oral corticosteroid use in the previous year. These are the common conditions which are important to identify because these are high risk traits, and in these patients the outcome or the control of asthma is going to be definitely bad, and these are the group of patients which should be followed up or monitored closely. So now coming to the pharmacological management, the 4 pillars of antenatal asthma care is regular reviews, that is 4 to 6 weeks monitoring with validation with questionnaires like asthma control questionnaires which are modified for pregnancy also. Treatment optimization by optimal inhalation therapy, control of comorbidities, and comprehensive patient education. 5 golden rules are: the patient on which the patient is controlled should not be changed or should not be stepped down during pregnancy. While initiating the therapies, the established and drugs with the most robust safety data should be used. The inhaled formulations should be maximized to be used, and exacerbations should be treated aggressively. And comorbidities should be addressed carefully during management of asthma during pregnancy. Now the contemporary paradigms are the anti-inflammatory reliever and maintenance and reliever therapy, that is as on-demand short-acting beta agonist with inhaled corticosteroids or long-acting beta agonist with inhaled corticosteroids. So we are aware of this AIR and MART approaches, and during stepwise escalation during pregnancy, during mild symptoms, one can use as needed low-dose ICS and formoterol. Step 3 and step 4, we should use low to moderate dose of inhaled corticosteroids with formoterol, and step 5, we should be using high dose inhaled corticosteroid. We can use long-acting antimuscarinic agents, and if needed, we can add a leukotriene receptor antagonist as well. Inhaled corticosteroids are safe to use. There is a myth that increased inhaled corticosteroids have got adverse impact on pregnancy, which is not correct. Discontinuation and maternal uncontrolled asthma is a larger risk as compared to inhaled corticosteroids, and this should be told and educated to all pregnant females. However, oral corticosteroids are associated with some gestational risk of cleft palate, but again, the development of exacerbation and inadequate treatment of exacerbation is far more dangerous than use of short course of corticosteroids during exacerbation, and this should be kept in mind. So the master care blueprint of pregnancy asthma is: do not guess, diagnose it with confidence, then actively rule out and identify all the treatable traits and treat them properly. Never stop the controller. ICS is protective anchor, and oral corticosteroid saves lives during exacerbations and should be monitored continuously and very stringently. Now a word about the gestational biologic therapy, which is mostly asked. It is seen that there is a passive transfer of immunoglobulins from the placenta across the placental membrane to the fetus, which has got a sigmoid curve, and it increases towards as the pregnancy advances. So there is a hierarchy that placental transport efficacy follows a specific IgG, that is, it is more in IgG 1 than 4, then 3, then 2. And the clinical implication, the high fetal exposure in late pregnancy, but minimal exposure during early pregnancy. So we have various biologic agents which are used during severe asthma, like omalizumab, mepolizumab, benralizumab, dupilumab, and tezepelumab, which are available, amongst which 3 are available for use in the Indian market, and which are various of IgG subclass. And a large body of evidence is available, at least for omalizumab, the strongest evidence that it does not cause long-term fetal malformations or long-term effects has adverse effects in pregnancy. There is good evidence for mepolizumab and benralizumab also to be used, which are available in India. And there are various cohort publications, although randomized controlled trials are difficult to be performed during pregnancy, but they are reasonably safe and can be used during pregnancy. So expert consensus guidelines is biological. If the patient is on biologics, it need not be stopped. If the patient needs biologics, patient can be administered biologic agents safely during pregnancy also. And the daily oral corticosteroid dose, if it exceeds more than 5 to 10 milligram, biologics should be preferably implemented because it has got a better safety profile as compared to oral corticosteroids for a longer time. Exacerbation should be managed in the same fashion as in a non-pregnant or general population. Maintain a saturation, first-line pharmacotherapy with SABA, SAMA, and inhaled corticosteroid and systemic corticosteroid should be offered. And physiological hyperventilation pregnancy lowers the baseline PCO2 to around 36 to 37. So whenever you see a patient in emergency who has a normal PCO2, it may be a sign of impending respiratory failure, and it should be seen with a very much caution, and it should not be ignored as a normal PCO2. So the take-home messages are that asthma is a common chronic condition. In fact, the most common chronic condition which pregnant patients come across during their course of pregnancy. It should be identified and adequately managed. The 4 pillars of management I have pointed out as the proper follow-up, adequate treatment, identifying of comorbidities, and stringent monitoring. The overexposure routes should be controlled. Patient should not be overexposed to any pharmacological agents, and wherever and whenever possible, safe and contemporary therapies should be implied rather than experimenting. So, thank you for patient listening. Any questions are welcome.
Thank you, sir. One question from my side. During the delivery, yes, sir, one question from my side. During the delivery, when asthma attacks in severe stage in exacerbation, what to do first add, and what the emergency ICU set up, what to plan before and after prepartum and postpartum?
Any patient who has got severe asthma and you are expecting during labor that patient may develop a severe asthma exacerbation, first of all, your ICU should be geared for these kind of emergencies. Patient who is on inhaled corticosteroids, a high dose of inhaled corticosteroids, and not adequately controlled even on that, during pregnancy, before conducting the pregnancy, patient can be switched over to parenteral corticosteroids or systemic corticosteroids. Should be kept.
Any side effect of the corticosteroid during for baby?
Yeah.
Any side effect of the steroid for baby?
No, that I very categorically told that any short course corticosteroids of 4 to 5 days do not have an adverse impact on the maternal or the fetal outcomes. So exacerbation management is more important than thinking about corticosteroids. If there is maternal hypoxia during labor or during an exacerbation, that is far more deleterious for the fetus as compared to exposure to short course of corticosteroids. So one should be treating with oxygen so that the saturation is maintained. one should be managing with short-acting beta agonist and short-acting antimuscarinic agents, inhaled corticosteroid, systemic corticosteroids if required, and early institution of non-invasive or invasive mechanical ventilation if needed.
Thank you so much.
Prednisolone do not cross the placenta.
Yes, sir.
That is number one. So it is very safe in pregnancy. I really congratulate Dr. Alok. You have addressed so many issues which were largely unaddressed by most of the physicians and the pulmonologists. I don't blame the pulmonologists, but the physicians do. And all the latest advancement like maps you are using, how it should be used, there are a lot of confusions about that. And it is safely can be used. And I'm really interested and very thankful to you. You have addressed the metabolic part of it. And especially GDM, which is exacerbated and least looked into. And then looking at the ABG, you look at the PCO2 and it is normal and you think that it is okay.
Gestational weight gain and gestational diabetes mellitus,
okay, in fact,
they have a direct impact on asthma control. Sir.
So, one simple question, sir.
Sure, sir.
Pregnancy, asthma in pregnancy, asthma during pregnancy. So, asthma in pregnancy is okay, it is your topic. During pregnancy, something, if you can tell.
Yeah, sir. As I told that asthma is the most common chronic respiratory condition. In fact, the most common chronic condition which a pregnant person comes across during the course of pregnancy. So sometimes you can also say that it is not the management of asthma during pregnancy, it is management of pregnancy during asthma. So our obstetricians and gynecologists should also be geared for these kind of complications and these kind of comorbidities to be managed properly. So when you coming back to your question, that if you come across a new patient, that's what I think you are trying to ask. If you come across a new patient who has not been previously diagnosed for bronchial asthma and comes with breathlessness to a general physician or to a pulmonologist, then all efforts, again I'll come back to the same, that all efforts should be made for a detailed clinical history and examination. Any history, because the dyspnea of pregnancy will not have cough, will not have chest tightness, will not have wheeze, will not have airway hyperresponsiveness and too much of paroxysmal coughs.
Correct.
Then these are the major clinical, very important points which should be detailed during history taking, and then a spirometry should be safely performed, and it can be very safely performed without any fear in all pregnant patients. If you do not have access to spirometry, then you can use blood eosinophils, you can use sputum eosinophils, and you can use your clinical information or compatible clinical to make the diagnosis of bronchial asthma, which is endorsed by the International Society of Obstetrics and Gynecology as well.
Sir, last question.
Sir.
We do all understand how to manage status epilepticus during pregnancy and how much the dose should be increased and what is to be done. In status asthmaticus, if it is happening in the third trimester or a second trimester or during the pregnancy, how you go about it?
The management of a severe exacerbation or status asthmaticus during pregnancy is no way different to management of status asthmaticus in any other patients. The bottom line is that. So you should be using the high dose of short-acting beta agonist, that is levosalbutamol in dose of 1.2 milligram 2 hourly, 6 hourly to 2 hourly as required. Then 6 hourly to 8 hourly of 500 micrograms of ipratropium bromide. Inhaled corticosteroid in the highest dose equivalent of beclomethasone, or the commonly used is budesonide, 1000 micrograms BD, and inhaled and systemic corticosteroids. The most important thing or most important component of asthma management is reducing the airway inflammation, which can reduce the dose requirement for mechanical ventilation or assisted ventilation. So we should forget about anything else at that point of time. Relieving the bronchospasm, decreasing the maternal hypoxia is the most important, or the most, I must say, the focus of attention for any caregiver during the course of bronchial asthma. exacerbation.
Thank you, sir. Thank you.
Thank you, sir.